Dr. Tom Lomax, welcome back to the Tokyo Living Podcast.
Hello, and thank you for having me back.
I think it's been a couple of months now. It seems like a while since you've been on.
Yes, yes, it's
Uh,
been a while. Been away for a bit over the summer, and I think I can't remember the last one that I did actually. But yeah,
Either can I, to be honest. But yes, it's the end of a long week, so my memory's not functioning at its optimal levels. We've got you on today as part of a specific series on mental health that we're running between World Suicide Prevention Day and World Mental Health Day. Within this series, I'm trying to get people from different healthcare professions and try to get, I guess, a few different perspectives on the management of mental health conditions. And I thought it'd be good to get the perspective of a general medicine practitioner, not necessarily a psychiatrist, but someone in general medicine that is dealing with people that are perhaps suffering from mental health issues. I thought we might start by just getting an idea of what sort of things you typically see in the clinic in the mental health space.
um, I mean, basically everything ranging from I guess the more common mental health diagnoses to depression and anxiety disorders, probably at the top of the list, through to more serious and more intractable problems. So, we'll sometimes be asked to be involved in care for people with eating disorders, and then, even things like bipolar disorder or psychotic disorders. Although when you sort of move to the more severe end of the spectrum, our advice has generally been for the expat community, especially for non-Japanese speakers, that it's very difficult for people who've got a major mental health problem, like bipolar 1, bipolar with mania, or severe depression with sort of suicidality, or psychosis. Those people don't really do well in the Japanese system, and they generally do need psychiatric involvement and sometimes inpatient care. So generally try to suggest that people are better looked after if they go back to their home countries at that more severe end of the spectrum.
Really? Yeah.
Yeah.
How often do you sort of see those cases where people are that repatriation is required?
Not very frequently. I think with the sort of demographics we've got with a lot of young families, eating disorders has probably been the most challenging kind of mental health problems we've had to look after, because particularly teenagers with eating disorders can do very badly, can really get very sick. But often, families aren't really in a position to send them back to their home countries. And even if they do, sometimes they're going back to countries where facilities for care aren't all that good in the home country either. So those can be very tricky. We are sometimes contacted by embassies as well. So consular officers will sometimes contact us because there's a foreign national who's come to Japan because they're going through some kind of a mental health crisis. And often when they get here, things will get worse, and we'll be asked to sort of come and provide sort of acute care and sometimes kind of sedation and repatriation. Yeah. So I guess that's the more acute end of the spectrum. But that's relatively rare.
Yeah, yeah, yeah. Do you see anything that's sort of more specific to Japan, or I guess specifically expats living in Japan? Is there any things associated with being in a foreign country, a non-English speaking country, away
Uh,
from family, that type of thing?
I think being in Japan can kind of act as a specific trigger or an exacerbating factor for some people with certain mental health problems. I'd say some families that move here, um, trailing spouses who've had to give up a job, for example,
Yeah, yeah.
are definitely an increased risk of mental health problems, because they're sort of simultaneously, if they're giving up their job, they're sort of losing the sense of role that comes with that. And then they're leaving behind family and social support networks. So that's definitely something that we see. And when I first moved here, you'd sort of tend to think of that as being like, wives, but as you're seeing more and more families where the main income earner is the woman, or a same-sex couple. It can really be anyone. Although actually, that's one thing that perhaps the pandemic has perhaps mitigated in terms of mental health problems, is there are a lot more opportunities for people to work remotely. So I think it's less common for people who want to continue to work to have to completely give up their role when they come to Japan.
It's very true.
But it can still be a factor. I think teenagers are also at increased risk as well. A lot of people kind of worry about younger children during relocations. But my experience has been that sort of children kind of maybe up to about age 10 or 11, as long as the family's there, they generally handle change of city, change of country relatively smoothly. Whereas teenagers are perhaps more heavily invested in their peer group as their, one of their main support networks. And if they're abruptly moved and they find it hard to integrate into their new school, then they can go through a rough time, and relocation can be a sort of trigger for for depression or anxiety particularly, and sometimes for more serious problems like eating disorders.
Yeah. Okay. And then you mentioned the pandemic before. I mean, is there anything that you've seen differently there in the last couple of years? Greater incidence of sort of health-related anxiety, things like that?
I think we saw that very much in the first year to year and a half of the pandemic. Some people became incredibly anxious, sort of inappropriately anxious about COVID, and, really to the point where it was interfering with family relationships and with function. I'm not seeing that so much this year. I think most people have kind of accommodated to COVID. And while some people are still kind of quite worried by it, probably the sort of more persistent impact has been kind of the block, people's dissociation from their social support networks, that particularly kids will perhaps spend a lot less time with their friends. I mean, that's not purely down to the pandemic, but I think that's something we've become more aware of, that loss of the sort of strength and depth of friendship relationships can be a driver for mental health problems.
From a general medicine perspective, how are mental health conditions typically managed in Japan, I guess, from your understanding?
You mean in primary care, like in what I do, or
more science?
So,
Okay.
I mean, primary care is not really such a thing in Japan. So, primary care as a specialty is tiny here. It's like less than 2% of qualified doctors. So if you spoke to Japanese people, they probably wouldn't think of going to see a primary care doctor with a mental health problem. But in the expat community, I mean, again, the expat community is quite diverse. And I've got patients who come from countries where, again, mental health care is all provided by specialists, is all provided by psychiatry. And people wouldn't think to consult with their primary care doctor. People will sort of say to me, "Oh, can you help with like anxiety? Can you prescribe medicine for these kind of problems?" But from my background, from the UK, probably in the UK, the bulk of psychiatric care is actually provided out of primary care. That people who've got mild or moderate depression or anxiety disorders may be entirely managed in primary care without being sent to, without being referred to psychiatry. So, I mean, I very much see that as being a core role. And I'll have people who'll come to see me kind of directly saying that they've got a mental health problem, that they feel that they're depressed or they're excessively anxious. But on the flip side, I'll also have people who I get the sense when I've seen them over a number of visits for sort of physical health problems, that actually they've got, a psychological or psychiatric issue that's underlying their physical health presentations. And then I've got to sort of make a judgment call as to when I step in and say, we've discussed like maybe a number of different physical symptoms, headaches, or chronic fatigue, or maybe sort of dizziness, rather nebulous symptoms that we've investigated and haven't found a physical cause for. And then I'll have to sort of decide if someone's receptive to the idea that actually they may be depressed or maybe suffering from anxiety as a cause for their physical symptoms.
Yeah. And I deal with that as well. There's musculoskeletal conditions that we see there being a very strong psychological influence, and same sort of thing.
I think people are more receptive to that message now. I think
Mm.
if I think when I first trained, if I'd said to someone, I think that perhaps you're experiencing this back pain, more because your underlying mental state's not very good at the moment, people's first response would be to feel they've been dismissed.
Yes.
So they'd sort of say, "Oh, you're saying it's all in my head. You think I don't have a problem." Whereas I think, now people are more receptive. And obviously, if I sort of say to someone, I accept that you've got back pain and, there are some physical reasons that are underpinning that. But I think all of us know that our mental state affects the way we perceive pain. And if we're not in a particularly good place psychologically, then perhaps we'll suffer sort of pain in a more acute way.
Mm, mm. And so if someone either does present to you with complaints of mental health issues, or if you suspect that that may be underlying another condition, how do you sort of go about managing it? Do you assess using questionnaires and things like that, or do you refer out at that point? And then how do you sort of combine the use of pharmacological interventions, and where does that sort of fit within other interventions such as counseling and things like that? I mean, so it's very, very patient dependent, but yeah.
Yeah, I think that's the essence of it, really. It's very patient specific. And I mean, a large part of it comes down to trying to sort of figure out what people's expectations are.
Mm.
That, people have got a sort of strong preference for managing, depression or an anxiety disorder without medication, with psychological therapy by seeing a psychologist, a cognitive behavioral therapist. I think it's probably more important to work with that rather than to sort of push someone down a different direction if they don't feel comfortable with it. So I generally start out by trying to explore, what people's ideas are about the problem they have, what kinds of intervention they've thought about. Like, have you thought about medication for this? Do you think it might help? Have you thought about seeing someone for some kind of talking therapy? I mean, have you thought about kind of environmental or lifestyle interventions? I mean, if your mental state's a result of extreme pressures at work, have you thought about trying to make some changes there? Because, if you're depressed because you feel sort of overworked and unrecognized at work, giving you medication probably isn't going to fix that and isn't necessarily going to be the right direction to take. So I'll generally start out trying to have a clear understanding of what people's expectations are. And then I'll kind of try to have a discussion about what the different options are for kinds of treatment. Whether people feel that they need to see a specialist, if they come from a country where, management by a psychiatrist is the norm, I'll go through what the options are for that. If people have, for example, been treated with medication before and it's been effective, then, I mean, often the most, the sort of most efficient, most sort of productive route to take is just to try to duplicate what's worked for them in the past, while trying to understand if their circumstances might have changed.
How does the use of medication in Japan sort of differ from, I guess, what you've experienced in the UK and what's typically used in other countries?
I mean, I think my perception on how medications used in Japanese psychiatric practice is that people will tend to be offered medication um, more quickly. I mean, Japanese
Really?
medical care doesn't really allocate very much time to patient consultations. And in any case, quite often, if people are communicating across a language barrier and across cross-cultural barriers, then there may be sort of quite a quick move to the Japanese doctor sort of saying, okay, this is your problem and this is the treatment for it.
Yeah.
And then there isn't really very much discussion about, are you prepared to take this treatment? Do you have any questions about it? What are the sort of parameters we're looking at? If you take this medication, might it cause side effects? And would that be a reason to stop taking it? So I think people often sort of walk out feeling that, they've just been sort of given a prescription and they need to start taking medication without maybe as much of a safety net or as many options as they might get if they'd seen someone in a Western setting. I mean, that's possibly a slightly distorted view, because those are the people who don't feel happy will then come see me. So, I mean, they're a sort of biased group.
Yeah.
But I've heard quite a few stories along those lines that people feel that they sort of very quickly moved from, these are my symptoms, and then, okay, this is your diagnosis, and this is a medication you need to take. Come back and see me in 2 weeks. And people can feel that's rather abrupt. I mean, even with more severe mental health problems. I mean, I've had at the extreme end a teenager who was taken in to see psychiatry and was told within 15 minutes, okay, that this child has schizophrenia and must start taking these antipsychotic medications. And that was kind of, I mean, it only takes you a few minutes on the web to realize that's kind of a lifelong diagnosis. So that's pretty devastating, and not something that I think in the West you'd ever hear that word dropped into a consultation, for until there'd been months of interaction.
Yeah. Okay.
Yeah.
I guess just a couple of more specific examples. You mentioned eating disorders before, and that's something you see fairly frequently out here. Somewhat frequently.
I mean, I don't know if the incidence of eating disorders is higher in our population or not. I mean, I would say, because my practice is looking after disproportionately sort of families and, families with children, that I think we probably do end up treating more eating disorders than an equivalent size practice would back home. I also think that there are, very few resources that people find that they're able to sort of make use of in Japan.
Yeah.
So we tend to be involved, sort of relied upon more than will be the case back home. So when I managed eating disorders in the UK, it would be in conjunction with a specialist eating disorders unit, which would have dietitians, psychiatrists, and psychologists, all of whom had quite a lot of expertise in managing eating disorders. That kind of infrastructure just isn't available here. So, when we have to manage eating disorders here, we have to sort of try to duplicate that as much as possible in-house, which can be quite challenging.
Yeah.
But I mean, having said that, because I think people have got more aware of it as an issue, I think parents will now flag concerns a bit earlier than would have been the case like 10, 15 years ago. And that does give us an opportunity to intervene at an earlier stage. And I think that often does really help, actually. I think by the time kids have sort of got down to, have lost kind of 20 or 30% of their healthy weight, then their mental state's really quite bad just as a result of kind of the starvation that comes with the disease. And then it's very hard to kind of get them to turn the corner.
Of course, yeah.
If you can sort of get in when maybe the ideas about food, eating, and diet are quite deep rooted, but the weight loss has only really just started, then I think you're much more likely to sort of have better outcomes, actually. So we've tried to be sort of more proactive, like flag eating disorders earlier, recommend treatment in a more sort of proactive manner at an earlier stage.
Yeah, that's really interesting, actually. Yeah. You mentioned at the start the more severe cases where you might think that the patient has sort of suicidal thoughts. How do you sort of go about intervening at that point? Obviously, that's potentially a life-threatening situation. If you suspected that the patient was in that sort of state of mind, but they weren't really admitting it or realizing it themselves, where do you sort of step in, and how does that sort of work? I can imagine that's an extremely difficult situation. And what are the sort of the resources, I guess, here in Tokyo that you sort of use in that instance?
Yeah, it is a very difficult situation. I mean, it's one that thankfully is relatively infrequent. But I mean, essentially, if we think someone's at genuine risk of serious self-harm, then we very much try to get their family involved. and we normally have to have quite a difficult discussion about the risks involved in them sort of staying at home if we think they're actively suicidal. That basically the options for so back home, we definitely look to get someone into a psychiatric facility where they could be observed and they could receive kind of more intensive therapy. But our experience of getting people into inpatient psychiatric facilities in Japan has not been good.
Really?
Again,
Yeah.
for sort of not Japanese speakers. So we really don't recommend that people in that situation look to be hospitalized in Japan. So we do generally try to involve families and talk about getting people back to their home country and into care in their home country as quickly as possible.
Are there any other sort of points regarding mental health management here from a general medicine perspective that you wanted to touch on at all?
I mean, I think that kind of covers the main points. I think when I first started, availability of medications was a problem because quite a lot of the psychiatric drugs, some of the antidepressants that were used very frequently in Europe and in the US, weren't available in Japan.
Mm.
And availability's improved during the time I've been practicing. So with like one maybe notable exception now, pretty well all psychiatric drugs that people would be treated on before moving to Japan are available. I guess the big exception really are medications for attention deficit disorder.
Mm.
So I mean that's been diagnosed with a massively increasing frequency, particularly in sort of teenagers, and the stimulant medications that are used in the States. While they are now available in Japan, they're very tightly restricted. So Vyvanse, which is an Adderall, which are essentially sort of modifications of amphetamine, which are used for attention deficit disorder in the States. It's very hard to get them prescribed here. There's a sort of limited number of facilities that can prescribe them, and only under Japanese health insurance. So we've got some expats who are here who don't have Japanese health insurance, and then they'll sort of say, well, how can I continue to get my son treated with Vyvanse? And the answer is that at the moment, legally in Japan, you can't. And if you bring those medications into the country, technically you're committing a felony. So you could actually be locked up for that. So that's still very tricky. And I think is going to continue to be a problem for the foreign community into the foreseeable future, unfortunately.
Yeah. Okay. I guess just to wrap up, one of the main reasons for sort of doing this is to raise awareness around mental health. From a patient perspective, if someone is sort of struggling with what they perceive as symptoms of depression and anxiety, but is perhaps a little hesitant to bring it up with their primary care provider, how would you sort of recommend that people go about that? And any other sort of last words in terms of the stigma around that?
I think people are less stigmatized by mental health problems than they were, although, again, there's a lot of variation between individuals and between different countries as well. We've got people from countries where mental health problems still are relatively stigmatized. I think by coming in to have an initial conversation with your primary care doctor, you're not sort of committing yourself to a diagnosis or to a treatment. I mean, I generally don't want to push people to take medication until they've had a chance to kind of think over the different treatment options, the implications of starting treatment with medication. So, I'm much happier going through, people's ideas about treatment, giving them some options to sort of take away and think about. And I'll very rarely suggest people start taking medication at the first visit. So I think, don't think that by going and having an initial conversation with primary care, you're sort of committed to a course of action. It's really just a sort of exploratory visit, hopefully.
Yeah. No, that's great. Well, I think that's it's been great to get the doctor's perspective on all of this. We really appreciate your insights and your expertise as always. So thank you very much again for your time, and yeah, we'll look forward to having
Great.
you on the show again soon.
And soon. Thank you very much. And
All
thank you
right,
for having me.
thanks, Tom.
Bye.
Bye.